Okay, so very warm welcome to everybody. My name is Christina Symes. I'm the Managing Director here at Gideon. And today we have a webinar by our very own resident epidemiologist, Kimberly Hazel. Just a couple of housekeeping rules. Please feel free to put all your questions into the chat whenever you feel like it. Please feel free to use the Q&A box, and we will leave all the questions for the end, at which point Kim will address them to the best of her ability. And that's essentially it. These are the rules. And I think we can hand over to Kim for this wonderful webinar today. So thank you very much.
Perfect. Thank you, Christina. Yeah, so we're going to talk about chickenpox, everybody's favorite topic. Definitely one of my favorite topics. One of those things that I don't know why I just find endlessly fascinating. So I want to start out with some trivia, because as any of you that have joined in our other webinars will know by now, I love trivia. I love it. So we're going to start there. So Christina, if you would show our first trivia question of the day, and give you guys just a little bit of time to answer. Which one of these is not a pox virus? Is it smallpox, monkeypox, chickenpox, or pseudo-cowpox? Go ahead and put in your answers now. All right. I hope that that's enough time for everyone to have started to get some answers in here, so we can look and see which one you guys think is not a pox virus. Yeah, so a lot of knee-jerk reaction would be to say this pseudo cowpox because it's got pseudo in the name, but it actually turns out that it's chickenpox. Chickenpox is not actually a pox virus; it's a herpes virus. So that kind of leads us right into just jumping into it and talking a little bit about chickenpox. So can you guys see my screen? Is that still up for everybody? Awesome, perfect. So within Gideon, we can see all of our different diseases in the disease notes. So what I'm showing you guys right now is a disease note for varicella or chickenpox. So this is some of the different information that you can get just through Gideon, and then we're going to talk a little bit more in detail. Things to know about chickenpox in general. It is a very contagious disease. It actually has an R naught, which is its reproductive number of 10 to 12. So a reproductive number is the average number of people who will contract a transmissible infection, basically going from one person to another. So for example, for every one person who gets chickenpox, they are likely to infect up to 10 to 12 other people on average. Some of this comes down to the way that it's spread. A lot of it is spread through respiratory secretions, which is not something that I think a lot of people would associate with a rash, but actually this is the way that chickenpox is transmitted. The most common point of entry for chickenpox is actually the respiratory system, as well as the conjunctiva of your eye. That's also just like a really common place that the chickenpox kind of enters the body. From there, it actually tends to replicate within the nasopharynx and some of the regional lymph nodes, particularly those up in our necks. Chickenpox is broken down into two phases of viremia, or two phases of infection. And so the primary phase typically occurs 4 to 6 days after infection, and this is where the virus is actually being disseminated into a bunch of other organs. So a lot of us don't think about the fact that chickenpox starts somewhere before it's a rash, and the places that it typically starts are some of those what we refer to as meaty or tissuey organs, such as the liver, the spleen, and also sometimes even in your sensory ganglia, which again, not a common thought to be considered as part of chickenpox or how the virus actually impacts the body, but it's a huge spot as to where the virus actually is attacking within the body. The second viremia, or that second phase, is actually the viral skin infection that we're so familiar with, that itchy and scratchy rash that you tend to feel all over your body, or that we are very familiar with seeing pictures of children with those red pock marks all over. Once someone has the virus or they've been exposed to someone else with the virus, typically takes about 10 to 21 days for these symptoms to appear. So they could have it for a good while before they actually start really noticing the symptoms, which is part of what makes it so transmissible, is that you could be spreading it well before you actually know that you really have it. One of the things that a lot of people also don't really think about when it comes to chickenpox is complications. There turns out to be quite a few of them, And some of them include things like pneumonia and encephalitis, and other things are more common, like a secondary bacterial infection. These are pretty common with chickenpox. The usual suspect for causing that is strep, and particularly group A streps. Those tend to be what we see causing these secondary infections. Looking more at some of the epidemiology of chickenpox and actually kind of assessing it and looking at it kind of at a wider lens, and rather than some of this clinical information, is definitely something that's important to do, and something that I think that gets overlooked a lot of times, especially by people that are just medical professionals that are in hospitals or primary care settings. Within Gideon, we can actually do that, which is super cool. Just as an epidemiologist, I really geek out about the fact that I can go in and be very country specific of what I want to look at. So if we wanted to take a look at the United States, I can go in here and tell it that that's what I want to see, and I want to see my country note here. So now I can look specifically at chickenpox within the United States, and it's going to give me a whole lot of really awesome information. So there's a ton that you can glean from this. We're just going to talk about a couple little things within it in general, but specifically we know that within the US it's very common, and there are about 4 million cases, which include an average of a little over 10,000 hospitalizations and 105 deaths each year. So these are numbers that come from the CDC and some of their more recent chickenpox and varicella studies. We also see that there's 14 hospitalizations for every 1,000 cases in adults, and a fatality rate of 21 for every 100,000 cases in adults, and 1 for every 100,000 cases in kids. So we do see that those that get chickenpox when they're older do have a higher chance of having some type of fatality than those that are younger, which is part of why people tend to think like, oh, it's a childhood illness, and that's when you should get it. Otherwise, it's very scary. So that's kind of where some of that comes from. We also know that the incidence of varicella is the highest in young children, with rates declining throughout older age groups. Meanwhile, the prevalence, on the other hand, remains relatively high in adults, and some of that is due to that continued exposure to the virus and some of the waning immunity that happens as you get older. Chickenpox is considered both endemic and epidemic in its patterns of transmission, and so it is endemic to a lot of countries, and it does have some epidemic phases and things like that that can take place globally. So I like history, kind of goes with that whole trivia thing. And so I want to kind of pivot now from some of these general facts and a lot of information that I've just spewed at you about chickenpox and chickenpox kind of granularly, and talk about the history of it, kind of where it comes from. But before we do that, I want to ask you guys another question. So I want to know if you guys know when the first varicella vaccine was made widely available within the United States. I'll give you guys just a little bit to go ahead and answer that. When that vaccine was first widely available to public within the United States. And while you do that, I'm just going to go back over here into Gideon, where I can actually tell it specifically that I want to look at vaccinations. And I can just tell it I want to look for varicella, and it's going to give me that vaccine. All right, let's see what you guys thought. Yes, so it was first made widely available in the United States in 1995. 97 is also a good guess. That's when it started to gain some traction within vaccination programs throughout the country. 2001 being where we started to see a little bit of a drop off with people actually getting the vaccination. And 2006 is also a very special time that we'll talk about here in just a minute. So looking at the history of varicella, the very first recorded outbreak of chickenpox, which outbreak maybe not by modern terms, considering how long ago it was actually in 792 AD in Japan. And so it wasn't necessarily maybe what we consider an outbreak, but for them it was a massive outbreak at the time. In 1767, we saw English physician William Herbeden publish a paper first describing the symptoms of chickenpox. He was followed very shortly by another English physician named Francis Adams, who actually coined the name chickenpox and put it in print within a book called The Natural History of the Human Race. After that, in 1804, we finally got the medical name for chickenpox, which is Varicella-Zoster. Varicella being a Latin word for little pox, and zoster being a Latin word for girdle. Just kind of referencing the fact that usually most people that present with chickenpox will end up with a pock type girdle around the trunk of their body, made from the red bumps. In 1875, we have a scientist named Rudolf Steiner who demonstrated a specific distinction between chickenpox and smallpox. Up to this point, there was a lot of misunderstanding, and there was a lot of people that thought chickenpox just was smallpox. They were very convinced that they were the same thing. They looked very similar, and the pox was a pretty scary thing at the time. And so when people got it, it was kind of a little bit jarring and a whole lot scary. And so him finding out this difference between the two made a world of difference just with the understanding of what chickenpox actually was. In 1888, doctors actually then went on to find a connection between herpes zoster, which would be the shingles virus, and chickenpox. What's special about this discovery is this was a discovery that was actually made using clinical and epidemiological observations. So this is a part in which epidemiology played a huge role in determining the relationship of one disease to another. And this is one of the first instances that's actually recorded of epidemiology playing a role determining the actual patterns between two diseases, which I think is super fascinating. By 1954, we had some scientists that were able to finally use cell cultures to isolate the fluid from the blisters of patients with an active chickenpox infection. This was a huge step forward in the ability to potentially make this vaccine that we're looking at through Gideon here. They were actually able to finally get something physical to use in order to kind of experiment with. And it was a huge leap because by the time we got to 1970, we had the creation of our very first varicella vaccine. This vaccine featured a live attenuated virus, which is actually still very common in chickenpox vaccines today. And it was first licensed by Japan and Korea for use by all of the public that were aged 12 months and older. Meanwhile, on the other side of the world, we had the United States doing their own thing as per usual. So in 1970 to around 1995, pox parties were all the rage. So I always like looking at the outbreak maps that Gideon has around this time because I do think it's endlessly fascinating to see what was going on as some of the other worlds in the other countries in the world, pardon me, were starting to actually get vaccinated, and the US said, well, maybe not. So we could go through Gideon and we can get to our lovely outbreak maps, and I can tell it that I want to narrow in as close as I can get to 1970 all the way to, I like to go to 1997 just to give us a buffer zone. So you can see that a lot of the outbreaks sort of dropped off in other places in the world, but the US still was definitely battling chickenpox outbreaks. This is because those pox parties, they really stepped up in intensity in the 90s as well. The 90s is definitely filled with lots of great things, Jinko genes included, but we were mainly really looking at pox parties from a public health perspective. So a pox party, for those of you not familiar, is where one kid in the neighborhood would get chickenpox and the parents of all the other kids would say, all right, get in the car, we're going over to so-and-so's house and we're all going to get chickenpox today. The idea was that if their kid played with the sick kid in town, then they might get chickenpox and then they won't have to deal with it when they're older and it just won't be so bad. History actually suggests that parties of this nature had origins as early as the Middle Ages, but they really didn't gain traction until the 1970s in modern times. So this really led to a lot of different issues. We'll talk about some of the dangers of doing a pox party or just intentionally getting chickenpox a little bit later. But following on our timeline theme here, we can see that in 2005, studies began to show an uptick in outbreaks in the US, which is when the CDC started to consider that maybe they should create some better guidance on vaccination. So this is another thing that we can kind of look at some of these outbreaks and the scale of them within Gideon. So we can actually change our range if we'd like to. I'd like to just go ahead and get us all the way up to 2021 here and just look at an actual list, and we can see different countries, the year, as well as the number of cases. So this is one of those things where, again, looking at the year, we can see that different years definitely had very different experiences when it comes to chickenpox. By 2007, the CDC did decide that it was going to change its guidance. It did actually decide that they were going to recommend a second dose of the vaccination. So they wanted to go ahead and start getting people a chickenpox booster because they were noticing some waning immunity was contributing to these outbreaks that we were seeing. Up to 2012, there were over 1,000 outbreaks with over 13,000 cases of chickenpox that were studied within the United States by the CDC, which kind of led them to kind of confirm some of their assertions and ideas that the chickenpox is something you should be getting boosters for and that you should definitely be vaccinating for. In 2015, the CDC conducted further research on vaccination rates, and they found specifically that most outbreaks in the United States were due to under-vaccination. So this is where we're going to start to talk about the dangers a little bit of not vaccinating versus vaccinating and why that can be a problem. So we talked a little bit very briefly about the fact that there is another illness that's related to chickenpox, and that illness would be shingles or herpes zoster. So those who contract varicella are more likely to have that secondary infection later in life than those who are vaccinated. In fact, up to 20% of the people who are impacted by chickenpox via actually contracting it rather than getting a vaccination do go on to get shingles or herpes zoster. And I'm lucky enough to count myself among them, as I had it when I was about 13. After you've had chickenpox, the virus will lay inactive within your nerve tissues, typically near your spinal cord and your brain. It hangs out there until it decides it's going to reactivate. And that is when you start to get the infection known as shingles or herpes zoster. This is one of those illnesses that is increasingly common with age. It's very easy to see in those that are over 55 years of age. There are a lot of similar symptoms that chickenpox has to shingles and vice versa, but the special thing about shingles is that it's typically only across one nerve root. A lot of people will have a new shingles rash show up on them, either on their trunk, their neck, or their face. When I had it, I was lucky enough that I had it just up one arm, and that was it. It's commonly misdiagnosed for a few reasons. One of the main ones being that some patients will not actually even ever present with the rash, especially if they're older. They're more likely to just come in with severe pain. And so it's kind of hard to get to the root of that pain and where is it coming from and why is it along this one nerve root. On a tangent of that is essentially the fact that this increasing risk of pain and this pain lingering on is more likely as you get older. So not only could you have the pain from shingles and maybe you do or do not have the rash, it's very likely that that pain could stay there long after the rash is cleared up or you're no longer technically active with shingles. Something also very interesting about shingles compared to chickenpox is that outbreaks are exceedingly rare, especially when they're compared with chickenpox. Herpes zoster is approximately 20% as infectious as varicella, so it's not nearly able to spread at the same rate, and nor is it either able to travel person to person and create these outbreaks that we know with chickenpox are so common. So that leads me to my final trivia question that I have specifically for you guys today, and that is, where was the only ever recorded shingles outbreak? Where did that take place? While you guys do that, I can go up here and I can return back to our map layout. All right, I hope that was enough time for you guys to get some guesses in. All right, so it looks like everybody that voted suggested that the only shingles outbreak that we've ever heard of was in India. And that is something that we can find out through Gideon. So I can go up here and I can actually change my disease outbreak look very simply. And I can tell it that I want something like herpes zoster. And it does indeed show us that we have one outbreak dot out here all by its lonesome. And if we click on it, we can get a little bit more information and we can see that it was in fact in India, this outbreak. And from here, if I want to find out a little bit more, I'm able to just go ahead and click in and I can now see specifically herpes zoster within India and I can see when our latest outbreak was. So yeah, interestingly enough, outbreaks for shingles, like I said, don't really happen, and yet somehow we had one that happened. It turned out that there was actually an HIV pandemic happening within India, and they actually started to see that there was a very large increase in shingles happening around that same time, and they were very curious about what it was. So a handful of studies were done, and one in particular basically stated that they thought that the actual occurrence of this outbreak of shingles was specifically related to the immunosuppressive effects of HIV. And that is why we were able to actually see an outbreak of shingles, which we have never seen again after that. But just because I'm an epidemiologist and I really like the idea of public health and I think community approaches are super important, I kind of want to talk a little bit about what some of the current approaches are and why we've not really seen chickenpox end up actually being eradicated or on the eradicated disease list. So as far as current public health approaches go, the biggest one that you're going to see is universal and widespread vaccination. I mean, that is a huge thing when it comes to a lot of preventable illnesses. But when it comes to chickenpox, that's usually what the push is. If you look at public health departments or even, local providers and things like that, they're almost always going to be recommending a vaccination. And they're almost always going to be trying to get funding for some type of vaccination program. One of the ways that the US does this, encouraging its universal and widespread vaccination, is that we require immunization in schools. So because we encourage it in schools, a lot of people will default to, okay, well, I'll just get it so my kid can go to public school. Of course, there are opportunities for religious exemptions or other things of that nature when it comes to getting a vaccination being required for school. But for the most part, we have seen a lot of success with this in our public health programs across the country. In other places in the world, such as Italy and some other European countries, it's actually there's a little bit more of a government mandate and government requirements for different reasons and in different scenarios and instances. And so that actually has also seen a lot of success within the country of Italy specifically, as far as keeping the actual outbreaks of chickenpox down. There's also something that should be said about the fact that, well, chickenpox is still going to happen, right? And so one of the other public health approaches is just knowing what to do when that happens and what do we do next and how do we take care of it. So some of the guidance that's given by public health communities and things in groups like CDC and WHO and NIH and some of these other major groups that are health institutes or organizations or ministries and that sort of thing, is that basically the identification of one single case of varicella should trigger an appropriate intervention measure. This way, cases can be sources for potential outbreaks and they can be monitored before that outbreak really takes off. So I think a lot of times people will be like, oh, my kid got chickenpox, I'm just gonna take them home and never do anything or say anything about it. Sometimes people do or don't take them to the doctor and that sort of thing. But if they do make it to the doctor, it is really important that those doctors do notify the relevant sources and organizations, professional organizations within their community. So for example, if someone has chickenpox here in Indiana, we should actually be letting our local health departments know, because then they're able to be ready in the event that a large outbreak should occur, just because those complications are very possible for those secondary infections that we talked about earlier. So if we've got these public health approaches and we know that chickenpox can be prevented, and we know that if we get the vaccination, we probably won't get shingles, the question remains, why isn't it eradicated, right? We've got this vaccine, so why does chickenpox still exist at all? There's a lot of reasons for that. One of the biggest ones is just in general, there's a lot of vaccine mistrust. We've seen it across the board. We've seen it for things like COVID, but we've seen it long before that. And it's not to say that some of that is not unfounded. There have been a rocky history of vaccine releases within the United States and some other things that have happened that have made people a little bit more scared of vaccines in general. But specifically for chickenpox, there's kind of a low faith in vaccination and the need to do it at all, right? A lot of people think it's childhood illness. You know, you're going to get it, you're going to get a rash, you feel bad for a while, but you'll be fine. It's not a big deal. That's not always the case, but this does lead to some selective vaccination where people or their, the parents of children are not actually taking them to go and get vaccinated. They're just saying, I'm going to let nature run its course. You're probably going to get it and that sort of stuff. And while pox parties have dwindled in their number and intensity, they do still exist within the United States for sure. Another thing is fear. There is actually some fear with the varicella vaccine. So we talked about how we can actually use Gideon to look at these things. And I can go back to that vaccine page and show you a little bit of what I'm talking about in a visual sense here, in that there are some warnings, right? There are some warnings for this vaccination. Of course, there are for every vaccination. And while that doesn't necessarily mean everybody's going to have these things, there are about 5% of the children that are vaccinated with this particular vaccine that do go on to develop a mild chickenpox rash. And for some parents, that's enough to say, doesn't matter, the vaccine didn't work anyway, my kid still got it, rather than thinking, oh, well, this is what my immune system was supposed to do, right? This is what the child was supposed to have happen. A lot of them will see that, then they'll tell their friends. And we know that that word of mouth kind of can change everything. And perception is everything when it comes to creating public health measures. Further than that, we know that when people have the combined vaccinations, they have that MMR-MMRV vaccine, it is possible that there are some children who are susceptible to febrile fits, which is seizures that come along with their fevers. And that can be so scary, especially as a new parent. And, maybe this is your very first child and some of their first vaccinations, and then they have these seizures and these fits. And that could be enough to make it so where you never want to put your child through that again, and you never want to get vaccination again. And so seeing those types of things, it doesn't really come as a surprise that the vaccination rate is not as great as it could be. And that definitely leads to some of the reason why it's not eradicated. There's also a little bit of it that could be because that need for a booster vaccination and knowing that we need one is actually kind of relatively new in the world of medical interventions. That was 2006. And so there's still a lot of people that don't realize they should have that booster and have never gone back to get it. And that does lead to some waning immunity, which can lead to more outbreaks. Another major aspect of this would be funding, right? So funding kind of drives everything. And I think that that's, one of those things where it's hard to talk about because you don't want to say like, oh, someone's health or the impacts of health comes down to whether the government's willing to give us money for these programs or whether, the community at large is willing to give money. But there is a large portion of public health programming that does come down strictly to funding and doing a cost benefit analysis of, is this program worth it and how much is it going to help the community? So specifically within the UK, they're a great example of this. Their Joint Committee on Vaccination and Immunization actually found that a varicella vaccination program was not cost effective. The benefit to the community did not actually seem great enough for them to push forward and move forward with a vaccination program that was going to lead to a large uptick in vaccinations. So it is something that happens. It's something to consider, and it does play a large role as to part of why it's not eradicated. Then, of course, we do always have some fringe beliefs. And in every instance, there's always some fringe beliefs, right? And so there are two major ones that, while I personally don't feel they play nearly as large of a role in this eradication of chickenpox or lack thereof, they do play some role to some people. But I don't think that they are doing any more than funding and vaccine mistrust, in my personal opinion. But some in the community consider that the community benefit is super low because if we eradicated chickenpox, then the increased exposure that adults receive from youth in their community getting chickenpox would actually be gone, and thus shingles and some of the complications would be more common because that community exposure tends to act as a mini booster. And once we got rid of that, then we'd see more shingles. You can think about this, it sounds weird, but when you think about the fact the shingles vaccine is only given to older adults for that same reason, because those that are younger are typically going to still be exposed to it in the community. I guess it makes a little bit of sense, but to me, it just seems a little bit of a weird way to look at specifically this community benefit for chickenpox. Another one is that some people will feel that it's wasted time to focus on an illness that results in a carrier state, instead wanting to focus on the more dangerous one and done illnesses. So they think that there's not a lot of value in trying to vaccinate against varicella, because once you get it, it's in your body anyway, and it's going to stay there. And in their opinion, yada yada, you can spread it around anyway, you can do whatever with it, it's just going to live in you, and so it's not worth trying to vaccinate for. I'm not entirely sure I understand the full rationale behind that, because even if that's the case, it doesn't necessarily mean that you won't get it later. And if we didn't vaccinate for shingles, then you're more likely to have the complications from that. So I think that's a very interesting way to look at it. It's, again, not a reason that I think actually is playing a large role in why chickenpox is not eradicated, but it is something that's out there and that has been considered as a potential possibility. So with that, I kind of am wrapping up all of my information dumping on you about chickenpox. I'm really happy that you guys joined me today, and I guess I'm ready for any questions that you guys might happen to have.
Thank you very much, Kim. This was most interesting, personally to me as well. Okay, we do have some questions. So Mary asked, have there been any upticks in shingles diagnoses after COVID infection? And she followed this up with saying, I asked the original question with a thought, or whether COVID is one of the situations like aging and cancer that has a propensity to trigger the reactivation of the varicella in the nerve. Lots of people with COVID, lots of people into the higher age risk status, lots of these people were children before vaccine was available. Certainly not an outbreak in the usual sense. So Kim, what are your thoughts on COVID and shingles?
Yeah, no, that's a really wonderful question. We did see, just because COVID does kind of immunosuppress people in general, we did see increases of a lot of things. I wouldn't be surprised if shingles was one of those. I don't actually know that entirely offhand. We can actually use Gideon to kind of see if maybe we've got some newer amounts of cases. If we go back into our diseases here, we can see if Gideon's got any insight for us. But in my personal opinion, my knee-jerk reaction would be to say that does seem likely to me, just because the weakened immune system. And that wouldn't entirely be surprising. You're definitely dead on the money saying that these older populations that maybe couldn't get the vaccination and maybe haven't been exposed for a while are now on that end of the at-risk population for COVID, and that cross-section could be kind of a staggering impact factor. So if we look at this, go back to that outbreak map, and we can see if there's any other cases there. So we see that that's the only one that's considered outbreak, like we talked about. But I think if we look at some of the other information in here, we can see.
Perhaps it might be worth looking at the worldwide note in case there's been any reported upticks.
If there's other special reports.
In relation to COVID, it seems like there's not been.
I wouldn't be surprised if there's not been formal studies done yet, so we might not have like really nitty-gritty references to provide on this right now. It's definitely something that would be worth looking into. I do think it's a very fascinating thought. Again, we did see upticks of other things, and being that varicella is also respiratory and it's spread, it might not be that surprising. However, we did also have a lot of mask mandates, so not knowing the actual size of the virus of varicella, knowing if it does actually spread through the mask or not, I'm not sure. But that also could have maybe helped with some of the lowering of that, just like we saw things like the actual normal influenza and stuff like that kind of decrease during some of the pandemic, simply because people were being more aware of where they were breathing, where they were coughing, how they were washing their hands. It doesn't look like it's something that anyone has made a note of. It's definitely something that, again, I think it's very possible. I don't see why it couldn't have been in some relation to it, but obviously it's not something large enough to be considered a massive outbreak or something that's cause for a large amount of concern as of now. I
Right.
hope
So
that makes sense.
I guess that answers Leslie's question as well, then, where she said that is there any significant data reported or even allowed in peer-reviewed journals? So we would probably think that it's definitely allowed to report these sort of things. But have there been any significant data reported? Very likely not, because Gideon does follow over 32,000 sources every day. And we, as you can see, we haven't got anything that jumps at us in terms of associated outbreaks here.
And I think
Now,
some of it, just to cut in a little bit too, is something you guys also have to think about with that is that people are still researching COVID, right? But on the list of all the things that people want to look at with COVID and that they're considering important and things to look at, the relationship to shingles might be one of those things that's sort of off the beaten path, right? It might not be something that people are thinking, oh, this might be important to look at. I think a lot of people are still trying to figure out, okay, what's an effective treatment plan? How do we handle the long-term and lasting side effects? What do we do about long COVID? What do we do with the fact that you can get more than one variant at a time? What do we do with the fact that you could get subvariants of the same variant at one time? And what do we do about reinfection? And so I think the question is a good one. It's important that you thought to ask, but I do think that it's something that we don't have enough resources that are able to actually be dedicated to like those smaller kind of questions right now. So I think maybe in the future we'll see some of it. But as of now, we're probably not going to see a lot of data coming out with COVID's link to things that, again, are still sort of considered weird illnesses or things that children would get or just the older would get type of things.
so again, it comes down to public perception, doesn't it?
Mm-hmm.
Damon has an interesting question here. He says, what do you think about the data that shows a 21% decrease in glioma brain cancers? Should family history play a role in the decision to vaccinate?
I think in general, people should always consider their medical history and their family history in any decisions when it comes to their medical history or any medical decisions whatsoever. I think that's important, and I think it's important even when it comes to vaccination. In my opinion, just because I have studied public health and I've studied specifically epidemiology and infectious disease epidemiology, I really lean towards always recommending like do the vaccination. But I always kind of put an underlying thought process of it is always important to consider your own personal standing, right? And your own personal experience and your family's experience and how people have responded to other things. For example, I have a family history of kidney cancer, so maybe my propensity to drink dark sodas all the time is something I should really consider when making choices for beverages because that's really hard on the kidneys, right? And so I should try not to do that. Or if I'm prone to developing kidney stones and I know I have a history of kidney cancer, maybe I should avoid oxalate heavy foods or medications in order to not overload the kidneys. So I do think it's important that people consider it. As far as specifically the number and the statistic that you cited, I don't know a lot about that. I've not really seen a lot in that. My field of expertise is not really cancer in general, so I don't have a lot of real professional insight as far as that. But I do think that for any vaccination, everyone should always consider getting it, and then they should always consider what the impacts are and what their family history says.
Thank you very much, Kim. Just one last question for you. Is there anything in Gideon's database that would inform a study of other factors you have not considered in your assessment of vaccine value? For example, inconsistency in vaccine quality or vaccine failure. I think I can probably point us to the answer if we were to look at dengue vaccine. But I know you have a lot more to say about that than I do.
No, we'll start there. Because what I've got is just more generic as well. It's not specific to anything either. So, all right, I've made it to the dengue vaccine page.
Yes, so in here, so we have additional comments and concerns in regards to this vaccine. Many of you may know about what happened in Philippines when testing Dengvaxia, as it's known today. And this is the reason why we have these comments and concerns saying that only individuals that have previously experienced natural infection, therefore are seropositive, should get this vaccine. Otherwise, getting a vaccine could potentially be fatal. So that is one thing that we definitely note on the vaccine quality, and perhaps a failure of the vaccine here to do its job to a certain extent. So when we are aware of things like that, we will definitely put it into the database. I don't know if you wanted to add anything to that, Kim?
Yeah, absolutely. I mean, I think some of it too is again, we talk about that perception shapes everything, right? And so while Gideon doesn't necessarily give us like a specific note of like, oh, this is what vaccine mistrust is, I do think that there are things that you can see within Gideon. You can see the list of toxic effects and contraindications, and you can look at that, and it sounds silly, but even from a qualitative standpoint, you could see, okay, is this list really long, right? And if it is, it's very likely that the perception of that vaccination is going to definitely play a role in whether or not people get it. And I do think that to a point, if you're a provider and you're using Gideon and you're researching vaccines that you might be giving a patient soon, that it is a worthwhile thing for you to look at the toxic effects and contraindications within Gideon to determine if that really is a vaccine that you should give to a certain patient. You are kind of responsible for their care, and I do think that it's important for you to know sort of the risks that they could also be taking, especially if you are a family care provider and you're providing care for this entire family, and so some of the medical history and things like that. You might be able to look at it and say, okay, this is probably not what we want to give this person. Again, we talk about that example that I had with my kidneys and how I have to like determine what's best for me based on that. Well, my urologist, he does the same thing, right? So if I go in and I'm presenting with kidney pain because of a kidney stone, or I'm having these sort of issues, he can look and he can say, okay, well, in your imaging, we know that there's some extra scar tissue in that kidney, so I'm not going to use shockwave therapy on you because that's going to add more scar tissue, which could be very dangerous if your other kidney ends up cancerous, and then you're stuck with only a very damaged kidney. So as a provider, he's taken that responsibility to go the step ahead and the step above to make kind of a sound call and then give me a recommendation based on that. Ultimately, it's my choice. I can still decide that I want to get that therapy. And so I think the same thing plays a role in vaccines. And I think that Gideon can provide a very important insight in that regard, because you can see these specific indications in a nice, pretty little package here that you can just see as you look straight down. Does that make sense? Does that answer that for you?
I think it does, Kim. Okay, let me see. There is one more comment from Leslie. Um, okay, she says, right, so you're speaking from the epidemiology, public health context of disease outbreak data and public perception. What about the foundational biological science of person, population, and vaccine? Current risks being reported in microbiology these days suggest that mRNA viruses are designed to function by first impairing certain innate immune mechanisms, potentially making recipients vulnerable to outbreak. Apologies, I'll scroll down, of other existing latent viruses, typo mRNA viruses and vaccines. Okay. There is the full question. Sorry, it's a very long remark that's in the chat, so you're welcome to reread it. It would be interesting to hear your last thoughts on that before we wrap up the webinar.
Yeah, absolutely. So, I mean, my as far as like more hard science kind of background is specifically chemistry. So I don't have as solid of a microbiome foundation, if we're all being candid here. But as far as the actual risks, I have seen that, and I have seen that again. Some of those other latent illnesses have been coming back around, and I do again think that that's very possible. And it wouldn't surprise me if we do see an uptick of shingles in result of not only having COVID or having a vaccination for it and that sort of stuff. That wouldn't entirely surprise me. It's just a matter of, I don't know that it's something that people are going to dedicate a lot of time right now to doing really heavy data lifting and research on. So I do, again, agree with everything that you're saying. I do think that it is something that is really important, and I do think it's something that definitely plays a role. And I do think that later, when people are starting to look more broad spectrum at some of the other impacts and lasting impacts of COVID, then they'll actually see that there are going to be an increase of that. And even going further into, say, specifically those mRNA viruses and vaccines in relation to that, that we're going to see more studies come out that find more of those latent illnesses being in an increase.
Perhaps we should arrange our next webinar with Leslie as our guest and talk a little bit more about microbiology aspect. Okay, there's just one last question, I promise you.
Yeah, no,
Does Gideon include global data on vaccine policies and actual uptake by country, such as percentages of population? So again, I can point you sort of to the answer. So one, we do have graphs on certain vaccines and how well they've been uptaken by countries, but we also can go into a country note. So for example, if we went into a country note for United States, we would be able to see some graphs there of the most popular vaccines that we can track over the years. If you scroll all the way down, there we go. We will see the uptake of certain vaccines, as well as the vaccination schedule and exactly how that works. So hopefully that helps to some extent. We are always happy to answer more questions after the webinar. We'll be sending a recording to all of you from my personal email. So if you have any more questions, please feel free to reply to that email, and I'll make sure to work with Kim and our scientific team here at Gideon to provide you with the very best of answers and maybe even examples. Thank you very much, everyone, for joining. Thank you, Kim. It was an amazing webinar. And at this point, I will stop the recording.